A patient arrives in the ICU critically ill from another hospital on a baffle of different pumps delivering inotropes and vasopressors. When you look at the pumps, each one of them gives the dose of these drugs in mils per hour. Now you want to change your patient over to your pumps, but how do you know what concentrations are in the syringe drivers or pumps that the patient is getting? If you give inadequate doses, the patient's blood pressure may fall off a cliff. If you give too high a dose, they may become severely hypertensive. In this tutorial, we're going to look at 3 different vasopressors: norepinephrine, epinephrine, and vasopressin, what dilutions and concentrations are used, how to titrate them, and how we should standardize those doses. Bedside Tutorials in Critical Care. With me, your host, Pat Nelligan. The blood pressure. Vasopressors know your dose. In this tutorial, we're going to look at the dilution, concentration, and delivery of vasopressor drugs. I'm going to start with norepinephrine, noradrenaline, and then we're going to look at epinephrine or adrenaline, and finally vasopressin. To look at the titration of norepinephrine, we'll need a clinical scenario. The case is Maeve, who is 76 years old, and she's in septic shock secondary to a urinary tract infection. She was treated with 2 liters of plasmolite, intravenous antibiotics, and her mean arterial pressure is still 50 millimeters of mercury. A central venous catheter has been placed, and we wish to start a norepinephrine or noradrenaline infusion. In septic shock, the mean arterial pressure target for most patients is 65 millimeters of mercury, and this is usually achieved with a combination of intravenous fluids, isotonic fluids, and norepinephrine. The question here is, how do I make up a norepinephrine infusion? What is the starting dose? How do I titrate it upwards and downwards? And when should I start vasopressin? You ask the nurse to start a norepinephrine infusion and come back a couple of hours later, and her mean arterial pressure is a reassuring 66 millimeters of mercury. What dose of norepinephrine is she on? And you're told her dose is 10 mils per hour. Now, clearly, the drug dose is achieving the patient goals, and that's a good thing, but we need to have a realistic idea of what dose the patient is getting, and 10 mils per hour really doesn't mean a whole lot. It can mean different things to different people, and different hospitals have different approaches to norepinephrine, and this makes it very confusing. Traditionally, in hospitals that I worked in, we diluted 3 milligrams of norepinephrine in 50 mils, and that worked out at 60 micrograms per mil, and 1 mil per hour was 1 microgram per minute. As you will see, this is commonly still done with epinephrine. But then we were told to stop making up our own infusions because that is dangerous and there's all kinds of potential problems with that, and to use this particular product, which is a pre-diluted version of noradrenaline that comes in 50 mils, that can be drawn straight into a syringe pump, and that has a different concentration of 0.8 milligrams per mil or 80 micrograms per mil. That gets sucked out of the vial into this 50 mil syringe and then delivered via a syringe driver. And you can see the syringe driver is delivering this concentration at 4 mils per hour. Hence the reason why the bedside nurse may have said to me the patient's getting 10 mils per hour. So in the part of the world that I work, we use syringe drivers to give vasopressor drugs, but elsewhere in the world they use pumps, and these pumps are usually connected to larger bags of fluid with different dilutions. So this gets very, very confusing. If you go into your pharmacy and look for norepinephrine, you're likely to find a box like this, and inside the box there are several ampules that contain 1 milligram in 1 mil, and often the doctors or nurses or pharmacists will use these ampules to draw up a particular concentration of norepinephrine. If you're using the syringe driver approach, then this is what you're likely to draw up, either 3 milligrams or 6 milligrams in 50 mils, as opposed to the bottle of pre-diluted norepinephrine, that's 4 milligrams in 50 mils. If you use the pumps, you're more likely to use a 250 ml bag that contains one of 3 separate dilutions, 4 milligrams in 250 mils, 8 milligrams in 250 mils, or 16 milligrams in 250 mils. And that is a massively different concentration of the same drug in the same bag. And norepinephrine can be dosed in two ways, in either micrograms per minute or micrograms per kilo per minute. And these are vastly different numbers. And on top of that, on a syringe driver or pumps, the nurses may actually adjust the dosage not in mics per minute or mics per kilo per minute, but in mils per hour, such as in our case. Now, it may happen that you go to Maeve's bedside and the nurse informs you that Maeve is getting 0.3 micrograms per kilo per minute. In the world I grew up in, I don't know what to make of this because nobody has talked to me about mics per kilo per minute for norepinephrine. They've been talking about mics per minute for the last 30 years, unlike, say, dopamine or dobutamine, where we've always used mics per kilo per minute. And one of the questions you might ask is, well, is this very little or is that a lot? And it's important to recognize that, for example, in the SOFA score, that mics per kilo per minute is the way that norepinephrine, dopamine, dobutamine, all these drugs are usually dosed. And in fact, the standard of care in most hospitals in the world is to use this approach. You will not see mils per hour or mics per minute used in pediatric hospitals. They will always use mics per kilo per minute. So if we look at our 50 ml bottle, there's 4 milligrams in 50 mils. That's 4,000 micrograms in 50 mils. It shouldn't be diluted. So there's 80 micrograms per mil. 1 mil per hour is 80 divided by 60, which is 1.33 micrograms per minute. 5 mils per hour is 1.33 times 5, which is 6.65 micrograms per minute. Most of us consider 10 micrograms per minute, or 1/8 of a mil, to be a high dose. Now, Maeve is 70 kilograms and her dose is 0.3 micrograms per kilo per minute. What's her dose in mics per minute and what's her dose in mils per hour? Let's work the problem. So she's 70 kilograms getting 0.3 mics per kilo per minute. The dosing in micrograms per minute is 0.3 times 70 times the minutes, which is 21 micrograms per minute. There's 4 milligrams in 50 mils, or 80 micrograms per mil. The infusion rate in mils per minute is 21 mics per minute divided by 80 micrograms per mil, which is 0.26 mils per minute. You multiply this out to get 60 minutes, so it's 0.26 times 60, which is 15 mils per hour. And that is a lot of noradrenaline. So in this case, if you look at our patient Maeve, who's getting 15 mils per hour of 80 mics per mil, and this is where she is, and that is a pretty hefty dose of norepinephrine. But we also need to have a look at the entire range of dosage that patients will get depending on their weight. So if we look, for example, at 15 mils per hour for patients going from 50 kilograms up to 110 kilograms, on the surface, you'll see this as 0.4, 0.3, 0.2, and it looks like a small number because we tend to ignore the second and third numbers after a decimal point, and it doesn't look like there's a huge difference between these. So I'm going to be a little bit naughty, and I'm going to change the dose to nanograms per kilo per minute. If you look at the patient who is 50 kilograms, they're receiving 400 nanograms per kilo per minute versus the patient who is 100 kilograms, who is literally getting half the dose. And this is important because a patient may look like they're getting a relatively modest dose of norepinephrine, but they're very small. And in fact, they're getting a very high dose, and vice versa. A large patient is getting quite a few mils per hour, but in fact, the dose is modest. And that's why you really need to be using micrograms per kilo per minute. In critical care, we need to be very precise in our understanding of dosing. And unless the patient's mass is taken into account, we make mistakes. We cannot do research or compare across hospitals or populations, or even transport patients from one hospital to the next unless we're using a common currency. And that common currency is mics per kilo per minute. The starting dose of norepinephrine is usually 0.01 to 0.03 micrograms per kilo per minute. and then you work your way upwards. Now let's have a look at the alternative dilutions. These are the 250 ml dilutions, because in many countries, norepinephrine is diluted to 250 ml of saline or glucose delivered through a pump rather than a syringe driver, and it can be very confusing. 4 milligrams in 250 ml, a very commonly used dilution, I'll get back to that in a minute, works out at 16 micrograms per mil. But you can also put 8 milligrams in 250 mils, that's 32 micrograms per mil, or more commonly, and what I would consider the standard ICU dilution, 16 milligrams in 250 mils, or 64 micrograms per mil. There is also a tendency for people to use nebulous terms like single strength, double strength, and quadruple strength. And I find this really difficult. This is a very powerful drug that affects blood pressure. It's not a Belgian beer. And it's important that you just talk about the distinct standardized concentrations. And this is the concentration that I think you should be using if you're running norepinephrine through a central line from a 250 ml bag. Now, I don't want to confuse you excessively, but it's been my experience that in many hospitals, the 250 ml bag is not the exact quantity that is used. In fact, if you add 16 milligrams as 16 mils of norepinephrine to the 250 ml bag, that bag now contains 266 mils. But elegantly, the concentration of norepinephrine falls to 60 micrograms per mil. And that is the same concentration as we used to make up in our syringe drivers, 3 milligrams in 50 mils. And as a consequence of using this dilution, 10 mils per hour works out at 10 mics per minute. And for a 100 kilogram patient, that works out at 0.1 micrograms per kilo per minute. So this is an excellent approach, and it's a good alternative if you don't have pre-mixed norepinephrine available. Let's talk about peripheral infusions. We are now in the mid-2020s, and the era of drowning patients with isotonic fluid for sepsis is passing. And there is a movement towards using dilute norepinephrine through a peripheral IV catheter early to restore stressed blood volume to get the mean arterial pressure back up above 65 millimeters of mercury or within the normal range for that patient. So what we're going to do is we're going to take a 250 ml bag of saline or 5% dextrose, remove 4 mils, absolutely remove the fluid in this situation, and add 4 mils or 4 milligrams of norepinephrine. And the concentration works out at 16 micrograms per mil. This is 1/5 of the strength of that 4 milligrams in 50 mils ampule that we use through the syringe drivers. So that's 5 times the volume or 1/5 of the concentration. It's very dilute, it's very safe, it's not going to cause a huge amount of trouble if the IV tissues. Each hospital should have a protocol for this, and I really think that we all should be using the same standardized concentration of 4 milligrams and 250 mils. This is my hospital's chart or protocol for the use of peripheral norepinephrine. And you can see to give someone 0.3 micrograms per kilo per minute, a hefty dose, but that's what Maeve is getting. She would have to get 84 mils per hour to achieve this dose. So it's inherently very safe. If someone puts this up and dials up 10, 20, 30 mils per hour, they're not going to get an agonizingly high dose of norepinephrine. Let's move on to talk about adrenaline or epinephrine. Currently, there is no commercial premixed epinephrine infusion. And so you or your pharmacist are going to need to prepare this. And there are 2 different approaches. There's the 250 ml approach, which involves a dilute peripheral concentration of 4 milligrams in 250 mils, 16 mics per mil, exactly the same as the dose that I suggested for norepinephrine, or the higher dose of 16 milligrams in 250 mils, 64 mics per mil, exactly the same dose of epinephrine as norepinephrine I previously mentioned in these 250 ml bags. However, in the absence of the premixed dose, most hospitals are still putting 3 milligrams in 50 mils through a syringe driver. Sometimes, and I prefer if you didn't do this, the dose is doubled 6 milligrams in 50 mils and it's called double strength. But this is endlessly confusing and causes all kinds of problems when people don't know what's in the syringe. That particular dose of 3 milligrams in 50 mils or 60 mics per mil is a particularly nice and easy concentration. There's a lot to be said for this because 1 mil per hour works out at 1 mic per minute. And that means that you can say somebody who is on 5 mils per hour is getting 5 mics per minute. Of course, this tells us nothing about the relative dose administered depending on the body weight. And the dose is different from norepinephrine. So using premixed norepinephrine at 10 mils per hour is not equivalent to 10 mils per hour of epinephrine to a lower dose. And again, it's really confusing if you start dosing these in mils per hour with 2 different dilutions in 2 different syringe drivers. And again, you need to be extremely careful. Beware that the dose in mics per kilo per minute is hugely different depending on the patient's size. So when we're talking about epinephrine and norepinephrine adrenaline versus noradrenaline, there are several different concentrations out there used for infusions in clinical practice, alongside the mini jets in the cardiac arrest carts, the ampules that are in the pharmacy, particularly the ICU pharmacy, and it's so important to standardize dosing from patient to patient. In my view, this isn't even up for discussion. We should all be using micrograms per kilo per minute. What about arginine vasopressin? Vasopressin is that additive agent that we give patients in vasoplegic shock to restore vascular tone where they have run out of circulating vasopressin. It is hormone replacement therapy. And nobody is entirely certain when to start this particular agent. Everybody has an opinion. But in general, once the dose of norepinephrine has exceeded 0.25 mics per kilo per minute, you should strongly consider using vasopressin. If using the standard concentrations when you hit 10 mils per hour, you need to be starting this drug. Many intensivists, including myself, will start it earlier. And many of us will also wean vasopressin after the patient has been weaned off norepinephrine. Vasopressin is a peptide hormone. There is no evidence, thankfully, that varying the dose by weight changes outcomes, so the dose is fixed in critical illness. For example, in sepsis, the maximum dose that we use is 0.03 units per minute. Occasionally, in other forms of vasoplegic shock, we may go up to 0.04 units per minute. There are different ampules out there. This is our current ampule that contains 40 international units in 2 mils, and that needs to be diluted up to 50 mils with 48 mils of saline. I wish to give Maeve 0.03 units per minute, so how many mils an hour should I give her? Let's work the problem. So we have 40 units in 2 mils and we want to figure out how to give 0.03 units per minute. We're going to add that 40 units to 48 mils of saline, and that is 0.8 units per mil, 40 divided by 50, and then divide that by 60 to get 1 mil per minute. So 0.8 divided by 60 gives us 0.0133 units in 1 mil per minute. Now we need to figure out how to get 0.03 units per minute, and that's very easy. Divide 0.03 by 0.0133, and that works out at 2.3 mils per hour. And that is the correct dose to use in sepsis in the ICU. Now let's review this tutorial. If you are administering norepinephrine, noradrenaline, you need to know the concentration that you're using. It is safer to use non-diluted or pharmacy-made-up formulations to avoid user error. The dose should be in micrograms per kilo per minute, preferably, because of the huge variability that mics per minute produces between body weights. The dilution of vasopressin should also be standardized, and the dose of vasopressin in sepsis is 0.03 units per minute. A slightly higher dose of 0.04 can be used in certain circumstances. I hope you're enjoying these tutorials. If you are, please subscribe on YouTube, leave me some likes and some comments, introduce me to some of your colleagues or friends, and follow my blog at ccmtutorials.org.